Great, thank you. So I'm Murray Stewart, I'm Chief Medical Officer at Rhythm, and I actually sent in this title before COVID about addressing the challenges of placebo groups in rare diseases. I think more than ever, I think anyone who's in clinical trials realizes the importance of placebo, particularly in diseases where you don't know the natural course of the disease. And it's quite frightening listening to people's comments about COVID and the absence of good placebo-controlled data. So hopefully most of you are agreed that ideally we would, in clinical trials, we would follow the gold standard of double-blind placebo-controlled studies so that we can actually see the effect of placebo and a true delta of a treatment effect versus placebo that may reduce bias in the groups. But obviously, the challenge in rare diseases is the fact there are very few patients. And therefore, the question I posed really is, do you need a placebo group in all rare disease studies? I don't think rarity should be a reason to avoid putting a placebo group in. And I think where possible, you should try and consider a placebo group that I think will strengthen your data package. So I want to cover in this presentation some experience I've had where we didn't use a placebo group in a study. I want to discuss theoretical challenges about doing uneven randomization. And then I'm going to go in a bit more detail in experiences we've had at Rhythm where we put placebo group up front of the study and then placebo group in the middle of the study. And we're also discussing some ideas of having placebo group at the end of the study. And I want to discuss some of the pros and cons of where you would include placebo in your clinical trials. So what this slide shows is a study we did with Strimvelis when I was at GSK, where we did not have a placebo group in the study. So Strimvelis is an ex vivo genetic treatment that's used to treat the rare disease of adenosine deaminase severe combined deficiency disease, commonly in the world known as the boy in the bubble disease. So unfortunately, this is a very rare genetic disorder, probably less than 1 in a million. And young children who are born with this disease have a deficiency in the ADA enzyme. The absence of this enzyme results in the hematopoietic cells in the bone marrow not being able to produce appropriate neutrophils or T cells. And as a consequence of this, these individuals are exposed, when they're exposed to infections, really don't do well. They've got no immune response, and their morbidity and clearly the mortality is very high. So when I was in GSK working with an Italian group in Milan, we developed a one-time, one-off treatment. So what we did is we took the individuals with the ADA SCID and we did bone marrow biopsies. Part of the bone marrow, we took out the CD34 plus cells. Now these individuals obviously had faulty genes. So what we then did is insert a functional gene that would allow the individual, when the cells were reinfused back into that individual, to see if they would then produce their own immune response. It clearly was quite a tough procedure. There was only one site across the world that was doing it in Milan. We needed to do the cells infused with the gene live within 6 hours. We didn't do any frozen samples. So all had to be done in one go. The patient had to be prepped. They needed to have some suppressive agent so that they didn't react to the foreign infusion. So it was quite a procedure. Now you could say, well, why didn't you infuse the cells back without the corrected gene? And we could have done that, but the child then probably only had one shot at getting the infusion. And I really felt that was unethical to do a placebo-controlled infusion without giving this person an option to have the gene therapy. And thankfully, most people agreed that in this situation, it probably was unethical to have a placebo group. So fortunately, the efficacy and the safety data showed clear effect. So we knew the course, the natural history course, well worked out, infection, morbidity, and mortality. And even in 7 to 10 individuals, after 1 to 2 years, we saw that they were able to mount, first of all, their own immune cells. They were able to produce T cells. In view of that, they were then exposed more naturally to the world in terms of trying to live a normal life. And the great news is the individuals we've treated have had great success, reduced infection rates, and prolonging their life. So a very successful one-off treatment. It was clearly, the clinical response was clear that we didn't need to do a placebo. What was interesting, in review by NICE still wanted to say, well, you've only got 12 individuals, it looks like they've got less infections. And it was still quite staggering to me that people were saying, well, there was no placebo group. As a consequence, the company were asked to do close safety monitoring. There is a theoretical concern of malignancy with some gene therapy insertions, probably due to historical attempts at this type of therapy. We've got registries for these individuals, and I'm glad to say the treatment was approved without placebo, but as I've said, there has been needs for registries. So certainly you can get rare disease without placebo. So what about placebo groups with uneven randomization? So I think if you understand the natural history, certainly in the short term, you could do uneven randomization. You can see a lot of companies do this in phase 2, where they've got 3 or 4 arms with different doses against placebo. They show efficacy, and because the studies are short duration, there's no real safety issue. However, there are 2 occasions where I think you do need to be careful with uneven randomization. So if you're looking at effect of halting disease progression, you do need to be careful. So we were involved in a study looking at amyloid and amyloid cardiomyopathy. And the point of the treatment was to stop the progression of the cardiomyopathy. So obviously what you would hope is the treatment therapy would show no deterioration, but then that's relying on the placebo group actually to get worse. And if you've got a placebo group that happens to do okay, you suddenly don't show a delta between your small placebo group and the treatment group, because you've got no room, because the treatment group's not necessarily improving. You were hoping for the placebo group to deteriorate. In that sense, it actually backfires, and it would have been better just to have no placebo group and compare to historical comparisons. The other reason I don't favor this approach is really due to the uneven safety exposure. So I'll take a theoretical example. So if your product is looking at people who are at risk of depression or suicide, and you say, well, in this population, the expected suicide is 20–30%, and you do a study in 40 people. In the placebo group, there's 10, and each of the other groups have 10. And your placebo group only has 1 suicidal ideation, which may happen. It's 20–30% expected, so the placebo group do okay, but there is 1 event. The treatment group do what you predict, 2 to 3 in the groups. And then you look at your total data, and all people will see in the headline of your results, say you did a 40-patient study, the safety showed 8 events with treatment and 1 in placebo. Now you can scramble and explain why there are uneven events, but in a small biotech, I would suggest that this would be all over, even if you have science backing you to say there's no difference between placebo and treatment. It's very difficult to cover from this from a perception point of view. So I want to give an example of where we've looked at rare disease, where we've looked at placebo in the front and the middle of the study. To contextualize this for you, we've looked at people who've got POMC and leptin receptor deficiency. So this isn't common obesity. These people have genetic defects that are contributing to their obesity. And obesity starts at an early age, it's rapid onset, they present with unrelenting hunger or hyperphagia. They also have some other hormonal abnormalities, but this is very rare. And POMC is 100 to 500 in the US, and LEPR's a little bit more, but a rare genetic disorder contributing to the obesity. Now, we're using a treatment called setmelanotide, which is an MC4 agonist. We know the MC4 pathway is important in appetite regulation. If you've got a normally functioning MC4 receptor, it regulates your appetite, your energy expenditure, and your weight. With these individuals with rare genetic disorders of obesity, due to the genetic defect, they have abnormal signaling in the pathway. This results in them being extremely hungry all the time, hyperphagic, they have decreased energy expenditure, and their weight zooms up. The natural history of these individuals are they're gaining 3 to 4 kilograms every year. And we wanted to argue that we don't need a placebo because the natural history is they don't respond to therapy. The problem is in the obesity world, people say, well, no, I don't believe you. I think people will respond to diet and exercise, and therefore you need a placebo. So you'll see in a minute the data of the populations, including placebo in the middle of the study. But the idea scientifically was that setmelanotide would activate the receptor, cause a decrease in appetite, a change in energy expenditure, and a decrease in weight. The study design in POMC and LEPR to individuals started them at a low dose and then went to an open label phase. And then in the middle of the study, we had a blinded withdrawal where they had 4 weeks on placebo and 4 weeks active. The individual subjects didn't know when they were getting placebo or active. And following that, they then went on to open label treatment. Here's the data in the POMC. You can see in the graph on the left the change in weight, and this is percentage reduction in weight over 12 visits, which equated to 52 weeks. The placebo in pink or purple in the middle shows what effect placebo did. So what we saw is individuals lost weight in the open label period, and then when they went on placebo, you saw the weight go up, they went back on drug, and the weight went down. And even though that was only 4 weeks on placebo, they gained 4 kilograms in weight in 4 weeks. And the mean weight loss is 30% change in weight in kilograms, but 25% change in weight. So a really remarkable reduction in weight loss. The hunger scores, these people are very hungry. You'd be used as a visual analog scale. So most of them said, look, they're hungry all the time, getting scores of 9. Within a couple of weeks of stopping the drug, their hunger scores went right down to 2 to 3. And then in the placebo phase, as soon as you stopped the drug, the individuals felt hungry again and the hunger scores went back up. So here's a really good example by involving placebo in the middle of the study where you see the effect of stopping the drug. There was one disadvantage in the LEPR that some individuals, when they went back on the drug, struggled to lose weight and were less compliant. So there can be compliance issues if you suddenly throw placebo into the study. I'm conscious of time, so I'll just go through the other slides a little bit more quickly. We have looked at Bardet-Biedl syndrome. This is another rare genetic disorder of obesity. And what we've done in this study is we've started individuals on a double-blind period, but just for 14 weeks. Given the rarity of the condition, we wanted to see if people could go on therapy after a short placebo. So what we did is we put people on treatment and placebo for 14 weeks, and then we put everyone on treatment. The primary endpoint is looking at 52 weeks, where we look at proportion of patients who have achieved at least 10% weight loss at 52 weeks. And the secondary endpoint will be looking at the difference between treatment and placebo. So we will be able to analyze the effect of placebo. We've also thought, what about in obesity studies, particularly for us, why don't we give them treatment and then stop at the end? The advantage of that is everyone will get treatment for 52 weeks. And then the idea would be is if you stop treatment in one arm and give them placebo, you would expect their weight to go back up and the treatment group to continue. And I think from an efficacy point of view, it's certainly worth considering placebo withdrawal at the end of the study. The disadvantages of placebo at the end is assessing safety. So there won't be new cases of safety if they've tolerability of the drug to begin with, and they've had safety concerns at the start of the study. In the withdrawal period at the end, you won't really see a delta on safety parameters because those who had problems with safety dropped out for tolerance early on. The other ethical challenge you've got is, at the end of the study, all these people who've done well, you're denying patients who've already benefited and may deteriorate. You could put them back on, so this is certainly a way forward. So what I want to conclude with, sometimes in rare diseases, you're stressed because you feel you can't do a double-blind placebo-controlled study. What I've shown in this short presentation is that there are opportunities to do placebo in rare disease. I think if you understand the natural history and the condition you're treating, know the natural course of efficacy, and know the safety profile and understand the mechanism and on-target effects, there are certainly options for addressing the challenge of placebo in rare diseases. I'm not recommending one method over another. I think it depends on the disease, but certainly you should be able to find one way of including placebo in your studies. And certainly, having not done this until recently, I really was pleasantly pleased with putting placebo in the middle of the study and being able to show both the effect of withdrawing the drug, the effect of efficacy in that period. It clearly showed the drug was working because stopping the drug, we showed increase in hunger and weight. So hopefully that gives you some idea of thoughts of putting placebo into rare disease studies. Thank you.
Thank you very much. Marie?
Hi, Nick Tazapis here. Really enjoyed your presentation. The question that I have is, would you expand your philosophy of using historic data in common diseases where there's a lot more historic data about the condition? And wouldn't it be more unethical to use placebos in common diseases with thousands of patients?
Yes, I mean, I think that there is there. And certainly, you know, if you take something like diabetes, which I've had quite a big experience in, you would say, well, I know what the HbA1c is going to do. And therefore, if there is a reduction in HbA1c, it's going to be related to the treatment because we know what happens to HbA1c. But I think there have been studies, if it's done in different regions, and some people do well even in the common diseases just by coming into a study. So I still think and believe the best approach in the majority of diseases is always to have a placebo if you can. But I take your point. If you know the natural history, surely a delta would be a drug effect. But I think people are always surprised, and that's why I still recommend trying to include placebo where possible.